So what we're going to do is NUR203, Exam 3 review. Um, we do have a study guide. I do have that, what I call the worksheet that goes with it that I sent you. And let's go ahead and start and get her going. Now, please, if there's something you're not understanding, I really do want you to stop me. I'm not offended. I don't get upset. In fact, I encourage questions, okay? So if there's something you don't understand, let me know. So I always like to put something little cute, little stickers on here, and so I could put some here for you here. It is a lot of chapters, 41, 45, 46 through 49. So let's start with the endocrine system. Now, endocrine system is things that regulate, many things. Let's just talk about diabetes. Well, there's diabetes 1 and 2. And in children, especially the younger ones, if you see diabetes, it is type 1. And it is always going to be type 1. You'll never change as you get older. It's not like growing out of febrile seizures. It doesn't happen that way. So, what would you see in this child? Well, they're going to see the triad of 3 Ps, and it's called polyphagia, hungry, polyuria, urinating, and polydipsia, which means urinating, urinating, and urinating. And these children, you'll see them that they will lose weight. And many of the times, the parents bring them to the doctor because of the weight loss. 5 pounds on a child who weighs 40 or 50 pounds is a lot of weight, and they tend to see it. Now, sometimes you see an adolescent that's bigger, a BMI of 92%. If they're starting to urinate and start getting these symptoms, you need to test them. But remember, don't just look at the urination and think diabetes and do a hemoglobin A1C. Remember, it could be urinary tract infection, okay? And of course, we're going to monitor the electrolytes there also. So here are those 3 signs, same thing, different picture. We love showing pictures because sometimes that will help you more than just talking about it. And we know when it gets to the point where you are diabetic and you're starting to get to that ketoacidosis stage, this is what you start to see first. Now, hyperglycemia is just when the blood sugar is elevated. It's not always DKA. You can have a high blood sugar because you ate a piece of cake or you have stress. All of those things can cause it. So hyperglycemia is just high blood sugar. DKA is hyperglycemia with ketosis, which is ketones in the urine, which is, of course, your pHs will be low. So ketonuria in the presence of hyperglycemia is that early sign of ketoacidosis. So also, what are you going to see? So you have elevated blood sugars, you're urinating protein out because it's that digestion of fat and of proteins, and you're going to see them getting drowsy. They're not as alert. They have very decreased skin turgor. They're almost like a dehydrated. And then their smell of their breath, I describe it as a rotten peach. It is a unbelievable, sickening, sweet smell. And this is the key. You walk into a room and smell that, you know. And of course, that along goes with the dehydration, hypotension, and it gets to bradycardia. Again, another pretty picture. So if you can't take sugars and use them, you're going to go into proteins and fats, and then there's byproducts. Now, hypoglycemia is all of a sudden there's too much insulin there, or you forget to eat, or the dinner tray didn't come, and they just been covered for a urine, right? All of those things can cause it. What would you see? Nausea, vomiting, jittery, shaky, sweaty. All of these things would say, okay, this patient is hypoglycemic. So what do? Well, 2 things. Is the child awake and alert, or are they unconscious? If they're awake and alert, you can give them something. You can give them orange juice. You can give them some sugar cubes. Even skim milk is one thing they say to give. And how about honey? Honey can also work. It's quick sugar release. Now, if the kid's unconscious, give them glucagon. And remember, they will vomit. Put them on their side. Again, another mnemonic for you to look at to see hypoglycemia. Now, pituitary gland does two things. One regulates fluid and one regulates your sex. Okay, so pituitary, two things. Well, the posterior is all about releasing a hormone that has to do with urinating, whether too much or too little could be the dysfunction of pituitary gland. Now, when you're talking about too much, we're going to go into that too. But let's first start talking about the growth. The growth and for looking at how tall you are. So if you have too much hormone being secreted, which is your growth hormone, the growth hormone, if it's too much, you're going to be hyperpituitarism. And these children usually have pituitary tumors, is usually what it is. And then hypopituitarism, your child is very short and tiny. Many parents decide to go ahead and give them injections, subcutaneous injections daily. And they will give this as in the hormone to try to make their child be as tall as they can be. Better than being 4'6". I mean, at least you're close to 5 foot would be, a better size. So they do give it. But remember, this is subcutaneous. So it takes a lot of, willpower for the child and for the parent because it is an injection. Now, hypopituitarism, as I said, is that subcutaneous injections, and it's just an undersecretion of the pituitary gland. Hyperpituitary gland, you'll see things like precocious puberty. That means you get breasts too early. Or men, they could get, hair on their face, which is very early in age, very unusual. Now, the other point of the pituitary gland is about fluid, and fluid too much, too little. So there are two types. There are diabetes insipidus, which means that too much hormone of, it's also called vasopressin, which is in there, is secreted. And what happens is this child, even adult, urinate. And because you're urinating, you get thirsty, so you drink. Now, don't get confused with diabetes insipidus. It has nothing to do with blood sugars. It's only to do with fluid and fluid balance. So how would you treat either diabetes insipidus or syndrome of inappropriate antidiuretic hormone? We're going to be monitoring vital signs. If you're urinating a lot, you want to make sure that you're not getting volume depleted, right? And if you're holding a lot of urine, as in syndrome of inappropriate antidiuretic hormone, you're going to be monitoring intake output, daily weights, and you're going to be restricting fluids on this child because they are already holding all the fluid in. So diabetes insipidus, nothing to do with blood sugars. It's all about urine, polydipsia, polyuria. Diabetes mellitus has that third one in there, polyphagia. That is not diabetes insipidus. So monitor vital signs, looking for dehydration. And then the SIADH is, again, monitoring fluid balance, intake, output, your daily weights, and, limiting fluids. So there it is again, polyuria, polydipsia. One other thing about infants, sometimes you see them thirsty and crying to drink, and they're urinating, and you're suspecting that it is diabetes insipidus. If you give them a bottle of water, all of a sudden they're satisfied. And I've seen it. It's crazy, all right? And diabetes insipidus, it doesn't matter that if you give them fluid or not. Because remember, it's the hormone in the pituitary gland that's secreting that's making them urinating. It has nothing to do with drinking too much and urinating too much. How do we treat it? Again, intake, output, daily weights. That's your mainstay with fluid balances. And what we'll do is give what we call vasopressin, DDAVP. And how do you know it is working? Well, the urination decreases it. goes back to normal levels, and that's how you know. SIADH, again, this is the syndrome of inappropriate anti-diuretic hormone, which means you are not getting, you're getting against urinating hormone. That means you're holding on to fluid. Just think you just swell up all the fluids in there. You're not urinating. So everything that goes along with that, you'll be concerned. Again, something to do with fluid, intake, output, daily weights. And this child will be on low sodium. You don't want to keep fluid in there. And also you would be on fluid restriction on this one. So they would be on antagonists to help the diuretic to work. So they stop holding fluids. More pictures just shows you the both of them. Now, thyroid. Now, thyroid is just like adults, but the one thing we're concerned about with thyroid and what it does, it helps with children growing. That's the only difference there, okay? So signs and symptoms, the same, except in children, we would say that they're not growing the way they should because they need thyroid, and also it's cognition. They need it for their brains to work, all right? That child will be delayed if they don't have the thyroid hormone, if they're hypothyroid from birth. Now, one of the things that can happen is children could have Graves' disease, which is hyperthyroidism, too much. And too much can be dangerous too. So what they do is they put them on medications. And one of them is called Hyperthyroxyl. So one of the things we need to teach our parents is that it causes leukopenia. Leukopenia, which means you're apt to get infections because you have a decrease in white blood cells. So what do we be concerned about? Make sure these patients are washing their hands a lot because that can help with leukopenia, and we treat it with glucocorticoids, which means steroids that can help. We can always do the radioactive iodine procedure, but most of the children, they'll just go right to medications. Now, one of the things we have to concern ourselves about with hyperthyroidism and even hypothyroidism that's receiving medications, getting that thyroid hormone, too much can put them into what we call a storm. And everything goes up, 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 up. It's like a sympathetic response. Heart rate up, blood pressure up, your tetanus in your tightness in your chest, and your temperature goes really up, and it is an emergency. They need to get to the ER quick. So what do you see with hypothyroidism? Well, like I said, just like adults, but decelerated growth means these children aren't growing the way they should. But you're going to see the dry skin, they have those puffy eyes, they have sparse hair, and you could see a really good picture there. Their hair isn't as full as it should be. Constipation, just like adults, sleepiness, because you're down, and then again, cognition, mental decline. Again, here's your pictures. She's going to show you the differences. With hyperthyroidism, it's that exophthalmos, right? Big eyeballs. Now, adrenocorticosteroids, Cushing syndrome is too much. Usually you see Cushing syndrome when you have a child or adult who's on steroids. And the steroids can lead to a lot of problems. One of the things is too much of this cortisol, of this steroid in the body causes the child to have a certain looking appearance. You're going to have a lot of weight gain, and you're going to see it in the face and in the trunk, okay? These children will have these, what we call ruddy cheeks, but they're red. It's the other word for it, the medical term, they like ruddy, okay. Red cheeks, you're going to be seeing acne, and you're going to be seeing that big moon face on them. Again, big pudgy face and trunk on them, skinny arms and legs. So there we are. Another thing that that goes along with that. All of a sudden, they're going to get hair on their chin, which they never had. Gaining weight. You know, I've had steroids and really went into Cushing's, and I gained like 50 pounds on it because of my rheumatoid arthritis. And you gain weight. Doesn't mean you're eating either. Just means your body is just getting puffy. And you get those fatty, puffy, big everything that goes on. Remember, with steroids, it's poor wound healing, bruising easily. And again, remember, blood sugars can be elevated. Another part of the adrenal thing is what we call it's the sex thing, where they don't get enough adrenal hormones, they can have a mix. Am I a boy or am I a girl? It's called ambiguous external genitalia. You might be a girl inside and maybe have a penis on the outside. You can have a penis and a vagina. You can have testicles and a vagina. It all different things. In my life, I've seen one. And what we need to do for these children is to assign a sex. Are you a boy or are you a girl? Usually they do testing first to look at that. Electrolytes, because there is severe hyponatremia and hyperkalemia, which is cardiac problems, right? And what do? We give the cortisol, which is hydrocortisone, prednisone, that we will be giving these children for life. For life. Now let's go into neurological dysfunction. So many things can go on with the head. And things that we can do is a lumbar puncture is one of the things that we're going to look at. Head injuries, meningitis, swelling or edema, hydrocephalus, and of course, you think of neurologic, you think seizures. Now, seizures, I describe it as this. There's a somewhere in the brain that all of a sudden sparks and goes bzzz, and the body reacts to that electrical current. And it could be in many different ways. It can get to the point, of course, what we call those tonic-clonic grand mal was the old name of them. So one of those things is we call it, you can get to the point of unconscious, altered consciousness, and those involuntary tonic-clonic movements. And then there could be that post-ictal afterwards. Now, epilepsy is 2 or more seizures, unprovoked for no reason. It's not febrile, and in 24 hours. Now, one of the things about seizures, and then you see a single seizure, that's usually a febrile seizure. One does not make epilepsy, and parents will ask those questions. What is causes? What can happen? Why do we have seizures? Well, it could be number one, fever, right? It's not the bottom, but that's usually number one in children. But it could be that infection, could be lesions, hemorrhage, metabolic things can be on, trauma, falling down, right? Or a malfunction, genetic, or if you've taken some sort of toxin. Now, some seizures are after, illnesses, okay? And we need to know as nurses, how do we care for these children? Well, you can walk into a room and a child's having a seizure. Your goal is safety. Protect that child from injury. You can't put anything in their mouth, but you can clean the area so there's no sharp things around them. Put the bed rails up so they don't fall out. And if you can, put something to pad them because they will bang them and they can hurt themselves. You should take the bed, put it flat, and put them on their side because they probably will vomit after a seizure, especially if it's one of those, what we call those grand mal, okay? So these are the types. We have the simple partial seizures, complex, the tonic-clonic seizures. This is the one where flexion to extension, you're foaming at the mouth and you have that post-ictal don't remember after and usually don't remember during. So absent seizures are that what we used to call petit mals. And then we have the other types, but febrile seizures, tonic-clonic are the most ones, that are tested upon, but it could be any level of a seizure. Now, cerebral palsy is when you have these type of movements that are impaired and the child can't really control their muscles. There is the spastic, which when you think of cerebral palsy, you've got the children and that become adults that maybe have a little limp or maybe their hand is, not held in the right way and they're functioning adult. They become functioning adults. Then you have the child that you think of with cerebral palsy that, is spastic and they put their hands and they get tight and they can't control them. It's what we call the hypertonicity. Some of them can't stand. Some of them will have to be in a wheelchair and they have to be buckled in because they can slide out of them. So cerebral palsy, we usually look at it, we think it's that spastic. Now, children are always falling down, right? As I call the toddlers, my dive bomb children. These children jump, go on the floor, bang their head, and it could be no injury or it could be quite a huge injury, okay? So, one of the things about caring for these children, now, in the emergency room where I worked with for 10 years, we would get children in with head injuries that were playing baseball or playing football or soccer or whatever. And somehow they hit their head. They ran into somebody or they ran in, somebody else ran into them and they were knocked unconscious. Now, how do we as nurses know that the head injury is getting worse, right? So all of a sudden, you're going to see what we call this memory, this this consciousness. It's going to become so. You've already told them 5 times that when they slid into third base, they were safe. They ask again, or did we win the game? You've already told them 10 times, and they keep asking the same questions. That's their memory that's showing it. Another thing is if they're vomiting, not related to food, and it becomes more and more. Pupils, of course, if those changes are there, absolutely that is something that you see that they're fixed, they're not dilating, they're not reacting to light. Those are things that we know that head injury is really getting worse than what it was. And another one is where that child is asleep and wakes up crying with a severe headache. We know there's increased pressure going on there. So what are we looking for? Many of the things I just said. A change in the level of consciousness or mental status. This is where all of a sudden they don't, where am I? Or, did we win the game? All of those things. Restless, they're starting to get pressure in the brain. There's areas in the brain not getting oxygen, right? Because of that pressure. Restlessness. You can't wake them up. And it gets to the point of temptation, right? Where really just deep, painful stimulation, maybe. Vomiting more than 3 times, and I said not related to food. Pupillary changes, that blurred vision, double vision. If they're up and they're starting to walk and they're getting stumbly, and that's not normal for them, that is also part of it. And then, of course, that waking up from sleep with a headache, that is telling you that that head injury is getting worse. And then fixed dilated pupil is a neurologic emergency. It's telling you there's so much pressure in that brain. If we don't relieve that pressure, it's going to be permanent brain injury. Now, spinal cord injuries are something that we really, number one priority is to maintain that position so that we don't increase the injury that's already there. At the scene, many of the medics will put on neck collars, put them on backboards. Now, that doesn't stop once they get to, the hospital. You, as that nurse taking care of them, must make sure that they don't twist because it can end up with a paraplegic or quadriplegic because that spinal column can crack. A lot of times, these spinal cord injuries need to go to CAT scans, moving them from stretchers to beds and doing it in a safe way. Now, what is meningitis? Well, it's an inflammation of the meninges. Usually, it's due to either a bacteria or virus. Most of the time, believe it or not, it is a virus. Um, we know that the only way to determine if it's viral or bacterial is to do a spinal tap, okay? So we're going to do that spinal tap, and we are going to, number one, make sure that child knows what's going to go on. You're going to have them on their side. They're going to put their knees up to their chest and, to sit there and talk them through it. Absolutely. Now, if we see that um, fluid that comes off the initial, if it's clear, colorless, that's a viral. Absolutely. Now, I've seen them almost look like cream, white cream, and that is so many white blood cells you can't count. That is a very, very, very sick child. Now, remember, anytime you enter the spinal column, whether it's for spinal anesthesia, postoperatively, or during a spinal tap, make sure you don't let them sit up right away. They'll get a terrible headache. They need to lay flat still for 30 minutes and slowly increase them. And of course, give fluids. One of the findings that you see with meningitis in that bacterial one is bacteria love sugar. So you're going to see a low sugar. And then what you're going to see is they don't want protein, so it's increased. And as I said, it's going to be cloudy, milky looking. So how do we take care of meningitis? Well, if it's a viral, it's going to be fluids and it's going to be monitoring for fever and vital signs, right? And minimal stimulation. The lights hurt, sounds hurt, all of those things. Now, if it is a bacterial, your priority is those antibiotics, okay? I'll always with meningitis, because it's an inflammation of the meninges, you're going to worry about cerebral edema. Now, sometimes with cerebral edema, there's so much pressure in there, we need to give something to get rid of that fluid. And you're thinking diuretic, you're thinking of everybody wants to give, Lasix, furosemide. No. What is specific to the head? Mannitol. Mannitol works quick, it gets rid of the pressure, and it really will help that brain not have as much damage because of all that fluid in there, okay? So, taking care of any head injury, any meningitis, any of those, always, always watch intake and output. You can give too much fluid, it'll go to the brain. Again, do the same thing as just pressure inside the brain due to the injury. So always monitor intake and output, no fluid overload, okay? Children with meningitis, bacterial, will be on isolation for 24 hours. And remember, their eyes hurt. They don't like sound, so cluster care, okay? Now, if you see any change of level of consciousness, all of a sudden they're getting really sluggish, tired, they get headaches now more and more, and projectile vomiting, these are things that are telling you that this child has an increased intracranial pressure. Thing about infants, they've got that fontanelle. If you see it bulging and they're not as active, you can say, this is a child with meningitis. You can monitor it really closely. Now, a myelomeningocele this is from this week's lecture. This is the meninges and spinal cord that has pulled up from the bottom and ripped up and come outside the back. It didn't close. So meninges and nerves, spinal cord, are up in that big sack. So at birth, what is our job? Well, it's to maintain the integrity of that skin and prevent infection. That's number one. So get a bottle of normal saline, a sterile dressing, and keep it on there to protect it. Now, physically, what do we worry about? Well, there's going to be decreased sensation in the lower extremities. Many children will be in a wheelchair for life. They don't have hardly any feeling in the lower extremities. So sort of like nipple line down, you need to think, what do I have to watch? Well, the kid's not probably going to be able to urinate by themselves. Many of them will have to be, for life, be catheterized for urine. Okay, that's number one. And number two, remember the stool. Making sure that we monitor how many stools a child's having, making sure those intestines are working too. So with the myelomeningocele, many times, or just fluid in the brain, we need to keep that fluid from building up, right? We don't want that pressure. That's a lot of this lecture about decreasing the pressure in the brain. Well, we put in something called a ventricular peritoneal shunt. It's a tube that goes from the brain, it goes into the belly, and what it does, it maintains that the head doesn't get too much fluid in there. Now, one of the things about this tube is they're usually behind the ear, there's a pump. You are to never, never, never touch it. Only the neurosurgeon can touch that, okay? What is our job? We're going to measure head circumference. We're going to measure abdominal circumference, okay? So that will see, is the belly too big? Is the head too big, too small? We're seeing, is it working? And we do know that headaches and vomiting are a sign that the shunt is not working, okay? Duchenne muscular dystrophy. You know, we talked about muscular dystrophies, and Duchenne is the one they always like to talk about. This is in boys, ages about 3 to 7, you see it. It comes from mom. It's an X-linked inheritance. So mom does give this to her son. She wants more children. They need to do genetics. And they have to make the decision, do I want to try? If it's a boy again, it's 1 out of 4 that child could have Duchenne again. So what do we see? Well, you see a kid who's growing up normally, maybe slightly low cognition initially, you know, it takes longer to do things, but they'll be walking and whatnot, and all of a sudden, you're going to see them start waddling, falling. Gower sign is when what I do, I get on the floor, I got to get up. What do? I sit up and then I take my hands and I walk up my legs to stand up, right? Their muscles are so weak, that's what they see. You will see that lordosis, that big curve in the lumbar spine. You're going to see big hypertrophic muscles in the thighs and the upper arms. And as I said, mild to moderate mental impairment will be there. And these children are usually on the heavier side. They can't exercise as much because most of these end up by the end of school age. Many of them end up in the wheelchair because their muscles are wasting. Now, they usually die as in the teenage area, and it's the muscles that stop, the heart and the diaphragm, and that's usually why they do die. Now, as a new looking at these children and trying to diagnose them, what we do is something called an electromyography. It's called an EMG, and there's that picture up there that shows it to you. It's either tabs or sometimes they put needles in, depending, what testing they have. And they take a little bit of electric and they put it in there, and it will show muscle movement. And in Duchenne's, it'll be a delayed or a decreased amount of contraction. So the muscle's not functioning the way they should. Now, they have taken muscles all over the body and put electrical little things and watch them contract and contract. It's like they've gone to the gym and worked out. So they're going to have sore muscles when they're done. Let them know it, but let them know it's temporary. So once they do the EMG, they figure it out. They know that this child is Duchenne, and they're going to be needing physical therapy, occupational therapy, in order for them to keep their muscles moving. Now, near drowning, submersion. Well, the injury is that hypoxic episode. They've gone under, they've had water in their lungs, they've had a moment of hypoxemia. Remember that your priority watching this child, they could come in running around looking like they're fine, but it can go up to 72 hours later that all of a sudden then they don't breathe as well. So these children are admitted for 3 days and usually in a step down, at least, intensive care unit to be monitoring their oxygen saturations. So GI, well, GI is mouth to anus and anywhere in between. And one of the things we need to be concerned about with GI is fluid and electrolyte balances. You know, if you vomit, you're going to be in metabolic alkalosis, right? Because you're losing all your acid. And if you're having diarrhea, you're losing all your alkaline, so it's metabolic acidosis. Those are the two different ones there. Dehydration is serious, and it is more serious in children than it is in adults, and it really needs to be taken care of as soon as possible. Now, if a child is vomiting and cannot keep anything down, you're not going to want to give them more something to vomit. You're going to start an IV. And you want that IV to be of something with electrolytes, you know, whether it's Pedialyte, Gatorade, Powerade. And if you have a child who cannot drink at all, you're going to do it IV and you're going to do that bolus of normal saline. You know, normal saline is a bolus. We're going to give it, and it does help them get that fluid together, okay? Now, vomiting. There's different sort of vomitings, right? You know, we have vomiting, which is just a little spit, and we have vomiting, which is across the room. Now, the thing that the child is vomiting, they can't be given oral. You're going to start IV, and you're going to give a bolus of normal saline. Now, remember, bolusing fluids, you never, ever bolus with sugar, dextrose, or with potassium in it. So if you were, you know, looking at treatment, you're going to give a bolus of normal saline and afterwards start an IV of D5, half saline with potassium after we get that potassium level, right? And the one thing that is your determination of dehydration, electrolyte imbalances, is your metabolic profile. So you will, when you're doing, starting this IV, definitely, you're going to get that metabolic profile, that P8, that BMP, or whatever you want to call it. You want to know potassium and sodium and chlorides and glucose. And with vomiting, as you're giving them that fluid, you're going to give that antiemetic, but keep them MPO until we get that working good. Now, that pyloric stenosis is that projectile. You know, I get infants in the ER and they say they're vomiting, and they're that 1 month to 3 months. I'll say, so how are they vomiting? Is it dribbling or is it, you know, across the room? If they say dribbling, that's reflux, most likely. If it's across the room and it's projectile, this is pyloric stenosis. And it is the baby eats hungry, and I'm hungry, and they're always hungry. It gets in that stomach, and all of a sudden it's too much, and it comes up, and I'm telling you, it's 15 feet across the room. It's not, not a little bit, it's quite a bit. What I would do when I heard it's projectile, I'll put my hand up underneath their xiphoid process. And there is usually, they say it's an olive. I call it a little marble. And it's hard. And that's the pyloric valve because it's thickened with muscles. And you can feel it there. So as soon as I know this is projectile, what am I going to do? I'm going to tell the parents nothing more to eat because they're vomiting chances of aspiration, right? And I'm going to get an IV in them, and I'm going to just get hydration, give them fluids. And of course, with young children, you do monitor their blood sugars to make sure their blood sugars aren't too low. Now, diarrhea. Now, you can give them something to drink, can't you? Because this is just coming out the other end. So you give it, it'll stay in. So as long as the child is awake and alert, you're going to give oral rehydration therapy. It's that Pedialyte, Gatorade, Powerade. And then you're going to slowly introduce the diet on them. And of course, watch anything spicy. You want to give them more bland sort of diet. Now, dehydration, as I said, be careful with dehydration. It does create even kidney failure on children. So again, let's look at the fluids. IV normal saline, never bolus with dextrose or potassium. To confirm the dehydration is, again, that electrolytes, the basic metabolic panel, and never give them potassium on a child who's never voided. You could put these children into hyperkalemia, and we don't want to do that. So you get that basic panel, and then you can add it if you need. Appendicitis, right lower quadrant, burning point, right? We know that these children, they come in, they're bent over, holding their right lower quadrant, and usually they're limping on that right foot. And you're like, okay, that's appendix. Now, if they're in pain, they go to the OR, they still have an appendix intact. The pain stops, that has ruptured. What is our concern? Peritonitis. All those bacteria or whatever, chemicals or debris, let's call it debris, in between that small and large intestines and the appendix spews out into the peritoneal cavity and creates havoc. The intestines are angry, the area is angry, and it is miserable. So how do we treat it? Well, of course, they do the surgery, they clean it out the best they can, but post-operatively, you're going to have them on your unit. What are you going to do? Well, because those intestines were really attacked by this debris, they are angry. So you're going to be NPO, nothing by mouth at all. They're going to be on IV fluids, and priority is antibiotics. Again, itis, infection. You need to make sure that the infection gets, taken away. One of the other things, and you're going to continue any pre-op medicines that they're on. If they're on anything that they have to take every day, most of the time it will be continued. Now, one of the other things with the IV fluids and the antibiotics, you're going to be having an NG tube in. Now, why is there an NG tube on a child that's had a ruptured appendix? Well, remember I said those bowels are inflamed and they're nasty and they're angry, right? Well, you want to give them a chance to heal. So you put the NG tube down, it'll suction up any of the gastric juices or any mucus so that it lets that intestine heal. That's why it's there. Another thing you're going to be worried about is they have opened up an abdominal cavity that had an infection in there. So when they close the skin, it's actually 2 pieces of infected tissue. Make sure you look at it to make sure it doesn't open. This is one of those wounds that could dehisce on you. So be very careful and monitor it. Look at it. Make sure that it's still together. And of course, getting them up out of bed, all of those things, and pain medicine. Their tummies do hurt. Now, reflux is when the food goes back up in their esophagus. We need to take care of it so we don't burn the esophagus, right? So sometimes it's just by diet. The younger infants will get a little bit of cereal to try to hold it down in their milk. And that's the only time we give food in the young children below 6 months. But we can give things like ranitidine, which now they're giving Pepcid. They don't like Zantac anymore. But, Zantac is still, on exams and tests, so we say it. But we'll give Pepcid. And it's just all it does is reduces the stomach acid production because we don't want the acid, right, to burning up and down their esophagus. And if this is something with diet, with medicines, and they could add on every medicine that an adult would get, could be, your PPIs and all different things, but it's still not working. What they do is something called a Nissen fundoplication. This is surgery. And what they do is they take the top of the stomach and flip it up so they can't vomit. so it keeps the food down. You might have heard this in combination when they put in gastrostomy tubes. They usually will do a gastrostomy tube with a fundal plication. That prevents the food from going up again into the esophagus because you put big volume down there, right? So older children that are having GERD, remember, they're getting that fluid going up their esophagus a little bit. Could be like mini aspirations, right? So you might see that chronic cough. And of course, it burns and it hurts. So abdominal pain and heartburn. That's your older child. Now, hepatitis, think about what hepatitis is. It's the liver. What does the liver do? It helps digest fat. So if your liver's not working, what's one food you're not going to give or minimum? Fat, right? Now, high protein carbohydrates and high carbohydrates, because without fat, this child is going to be nutritionally depleted. They need those calories, okay? And as nurses, as families, what are we going to teach them? Wash your hands, wash your hands, wash your hands. And that helps the prevention of it being spread. So diet, low fat, high protein, and carbs. Celiac disease is your small bowel, and the villi don't like gluten. Gluten is wheat, barley, oats, and rye, and any foods that have any little piece of it. Could be macaroni, could be breaded chicken nuggets, all of those things. Today, actually, rice, they have rice cereal. They have corn flour, like tortillas, right? Those things can be used because those are good. But preventing them from having those things is what we do for celiac disease. It's all dietary. So dairy, meat, fruits, vegetables are all good choices, but no gluten. Now, bladder exstrophy is something like myelomeningocele. Something is born on the outside. First thing, what we're going to do, we're going to protect it, keep it moist by normal saline dressing, sterile dressing, protect the skin there. Their bladder, even though it's born on the outside, still urinates the normal way. It's just in a different position. And again, what are we going to do with the bladder? Concerns, monitor INO, monitor for infection, and then they'll do surgery and they'll put it back in. Mecodiverticulum is part of a diverticulum that doesn't, it's sticking out or inside the intestines, and it rips. And in it are blood vessels. And it rips and it spews from the small intestine. Blood just starts dripping. And you'll see it, when you move your bowels, or it'll come out your rectum. So what do you see? Well, you'll see painless rectal bleeding, minimal discomfort. And what they do is just do surgery and remove it, and they're fine. Hirschsprung's disease. This is a piece of large intestines close to, the anus that has no nerves. Okay? There's no nerves in it. So no peristalsis. It sits there and it gets bigger and bigger. It's a megacolon. It's an obstruction. And that's what it causes because it's immobile. It doesn't move. And because that chance of bowel obstructions, they're going to remove it. And what they do is what we call a two-stage surgery. They take that piece of intestines out and they make a colostomy. And then maybe at the end of the first year, they're going to close it back up. They give the other area a piece, just to relax. Now, one of the things that you do see with Hirschsprung's, see that tiny little thing that comes down? Sometimes a little is squirted out there. It's almost like frosting on a cake. So you see like this ribbon sort of stool there. That's the only thing that you would see, or you see that belly getting bigger, but this doesn't hurt them. There's no nerves in there, but surgery is required. Esophageal atresia and tracheoesophageal fistula. These are things that at birth, what you're going to see is a kid who swallows its own saliva and is coughing and choking. He's having mini aspirations. The esophageal atresia, there's no connection to his stomach. It just is a pouch, it sits there. And then that tracheal esophageal fistula is a connection between this esophagus and the trachea. So you eat, drink, goes down the esophagus, over into the lungs, and now you have these aspiration pneumonias. So these kids are usually normal kids, cognitively aware. At birth, what do we have to do? Well, these children cannot be fed. These children are NPO because they still have saliva. They're still swallowing it. There's still many aspirations. You're going to have them on IV fluids and antibiotics, right? You want to prevent these infections from going on. And because of normal growth development, these children, give them a pacifier, a non-nutritive sucking, because they do what with that? Self-soothe. It's a comforter, a self-soother. So they need that. Nephrotic syndrome has nothing to do with kidney failure. Nothing. The kidneys are working. They're working great, but they don't like protein. So they take all the protein and they get rid of it. So what do you see? Well, you're going to see protein in the urine. Where does protein come from? It comes from in the blood. Protein, albumin are the same thing. In the blood, it's there. You give medicines, it hops on, the little albumin goes around. And what doesn't get hopped on is free drug in the body. So you got to be really careful giving medications to these children. So what do you see? Well, because the blood now is trying to do this equilibrium or isotonic thing, it takes a lot of the fluid and pushes it out extracellularly. These children have big, puffy eyes. Even their tongue and their cheeks inside get all puffy, and they try to eat and they're biting on them. And that's a big issue with these children. So you have all of this fluid. You have all this protein being lost. Well, number one, what's the treatment? Well, the treatment on this child would be steroids. As nurses, what do we need to watch? Well, again, this is kidneys, this is fluid, this is intake, output, daily weights. Now, you're retaining fluid, salt restriction, fluid restriction, okay? Acute glomerulonephritis usually and can be a common side effect of not treating a strep infection. And if you don't treat the strep infection, it can go and attack your kidneys. And what you're going to see is you stop urinating. You're not urinating, fluids going in your body. So you see again that periorbital edema. All that fluid causes hypertension, headaches. You're going to see red-brown urine on these children. You're going to see blood pressures really high on these children and proteinuria. Now, again, fluid, what are we going to do? Daily weights, intake, output. And this one, because the kidneys are in the peritoneal cavity, we'll be measuring that abdomen. Again, we're going to be low sodium, fluid restrictions. And one of the things about acute glomerulonephritis is they're very susceptible to infections. So again, hand washing for those children. Now, in this study guide, I made sure I was trying to put a point across of really what do they do for this hypospadias, epispadias. Remember, hypospadias, the opening to the penis, the urethra doesn't come to the tip. The hypo's underneath, anywhere underneath, and epi is on top. And usually they'll say even before 18 months, but usually they try in the first year to do it, where they'll fillet the penis open, they'll create a cavity. They're going to put a catheter in there, and they use the foreskin as the plastic closure. So this child cannot have a circumcision. For the Jewish faith, this might be something. So they need to know why, that they're going to use it to help make the penis function the way it's supposed to, right? And they want to do it before they're potty trained. Now, that tube they put in, whether it's like a little catheter or a little plastic tubes I've seen in there, it's going to be there for 10 or 14 days. You don't touch it. Just keep it inside the bladder, the diaper, so it doesn't have urine everywhere. Chronic kidney disease, the things that we worry about that is it gets worse as it keeps going. We know that this child doesn't have red blood cells because of the erythropoietin, so they give erythropoietin injections to these children. And one of the things is they lose vitamin D and calcium. And they give it now because it's for bone health. It can cause what we call osteodystrophy, or poor bone shape and malformation. And we want to make sure, if possible, that we keep those bones as straight and as healthy as possible. Dialysis in children, the younger children cannot be on hemodialysis, so they're going to be on peritoneal dialysis. And peritoneal dialysis is a catheter right into the abdomen. And it goes into the abdomen, and we put fluid in there. It sits, and then we'll empty it. And it's done at night. And it's on a machine that gets this done. And it's warmed, what we call diastolate, that goes in so the body doesn't get a shock from it. And the difference between what is in the bag from what fluid we inserted to what's left is your urine output. Now, what do we need to know as nurses taking care of this? Well, if we see that urine that's coming out is changing color, that color, or there see little something in the fluid, it's not right. It's probably showing there's an infection. And, they use super sterile procedure to hook these up, but sometimes there's always a slip in, what you're doing, and an infection could, go inside. So as soon as we see this change of the color of diastolate, the fluid that's coming out, probably infection, call the doctor immediately, and the doctor will order an antibiotic. Renal biopsies are very similar to the care of a cardiac cath. Same sort of thing, which means bed rest afterwards. There's going to be a pressure dressing or sandbag on where that kidney was. And we're going to be monitoring output because we've inserted a needle in the kidney for a biopsy. And we're going to be also watching the abdomen to make sure it's not getting big or tender, fluid oozing into the abdominal cavity, okay? So you've messed with the kidneys, intake, output, monitor that bandage, and they will be 24 hours in bed rest. Now, transplants can happen. One of the things that is the number one thing is rejection on these children. So rejection means you're getting that fever, swelling, the kidneys are not working, blood pressure's up, et cetera, et cetera. So the one thing is that they'll be on immunosuppressive therapy for life. And because of the kidneys and that anemia, the erythropoietin is also given for them. So what would be one of those nursing diagnoses? It says risk for infection related to immunocompromised state and post-transplant medications, right? We have made you immunosuppressed. You have to be careful. Fractures, we know they're simple, open, complicated, comminuted. Well, simple are the ones that the bone hasn't come through. And then open means that they've touched the air, and they've got some contaminants in there, and the risk for infection is high. So these children will be on IV, or, if it's a tiny little one, could be PO antibiotics, or it could be IV, but antibiotics for sure. So that's what we're concerned there. Those are the types. You want to look at them more. And now cast care. Well, why don't we worry about cast cares? Aren't there a bunch of those P's that we look at? Pain, pulse, pallor, paresthesia, paralysis. Those are things that we look at. So if we are seeing any of them, these patients are told, back to the doctor. So we know, put nothing in there. It should be air dry, wiggle the fingers, and keep it elevated. Traction. There's skin traction and skeletal traction and cervical traction. What does traction do? Well, it pulls something to keep those joints in line, whether it's the spine, whether it's the femur bone, whatever it is. And what that does, it puts those bones more together and it prevents all of those muscle spasms. And they do, it says rare. I've seen femurs where they're really complaining of pain. Put them in bucks traction, pull it, get those tips together, and it does decrease. And again, it starts that healing process. One of the things about traction that has weights on it, make sure those weights are free flowing and that they are pulling the way that they should. That's the biggest thing that we see with it. You document the weights and you keep them 24 hours a day. You never take them off. DDH. This is your dysplasia of the hip, developmental dysplasia of the hip. We know that the sooner we get to it and try to correct it, the easier it will be. And infants heal really quick. So the sooner we get them in a Pavlik harness, the better it will be. So you've got your hip and you've got your femur, and the ball of the head of the femur is born up here. And they've got to pull it back and get it where it needs to be. And what they do is they put them in something called a Pavlik harness. And it's abduction of the hip, okay? Abduction. And eventually it will pop back in. Sometimes they don't, they'll put them in spica cast, and older kids might need surgery, but it usually will work. Remember with these Pavlik harnesses to have a t-shirt underneath and long socks underneath so that it prevents that rubbing, and really monitors skin on these children. Scoliosis, what do you see? Well, you see the longer arm, you see the curved back, S-shaped type of thing, curvature of the spine. How do we treat it? Well, if it's less than 45, it's just going to be put them on a nice brace, and we're going to do a lot of exercises, strengthening the muscles in the back and the abdomen to hold that spine straight. Above 45, you will need surgery. So if you see it at 50, it's surgery because it's impeding upon the lungs. They need to, that's curved like that, pushing that lung, and we really want to open it up so that they can breathe well. Remember, this is usually your pre-adolescent, that adolescent time. So remember, they're all about their body image. So remember that as we are, maybe have to teach them how to use this brace. All of that. Osteomyelitis, an infection that gets to the bone. I mean, a lot of times I see these children stepping on something in bare feet outside, right? So what do we see? We'll see a red, swollen, painful, let's say it's a toe that's got it. And then all of a sudden, you're going to start seeing them with fevers. You take a CBC, white counts are elevated. How do we treat it? Well, number one, the point of entry must be cleaned, of course, but then it'd be a long-term antibiotic therapy. That infection's got to the bone, and it's 2 to 6 weeks, and usually it's more on that 6-week side. Remember, these children will probably be on some sort of rest. If it's in the foot, they're not going to want them walking on it, so complete rest, immobile where it's at. And always remember nutrition. These children need some good protein to aid in healing. Sometimes it gets bad and they have to do surgery and remove it. So fixing it as quick as we can is the most important. Now, lupus, the body attacks organs. It says organs, I don't like you, and it goes for them. It's autoimmune. This is the one that you see that we call a malar rash. It's that red cheeks butterfly rash, right? One of the things is that photosensitivity, being careful of sun, using sunscreen and limiting the amount of time in the sun. You're going to see oronasal ulcers, you'll see arthritis, and many other things that go along with it. And it's usually your right there at puberty, and a lot of times girls. We use steroids, prophylactic antibiotics before procedure, any sort of procedure on them. And, you know, this child really needs to be good with following up with the doctor and let people know. Now, JIA is just like lupus, right? But JIA, or rheumatoid arthritis, it was called, is the body attacks the joints. So what do you see? Well, you see swollen joints, joint inflammation, and it's worse in the morning. In the morning, it's hard. I mean, I've told everybody I've got rheumatoid arthritis, and in the morning, or if I have to get up during the night, I have to sit there a second. I have to stretch a second because it is stiff and it takes a moment. If you're a child, it's going to be some growth disturbances in it. And if not treated, and even sometimes when treated, the joints can be disfigured. I mean, you've seen the pictures of all over the fingers or feet, but the goal is to try to keep it as calm as possible, right? And there's something called uveitis, where the iris gets inflamed. So they really need to be monitored by the eye doctor, okay? Guillain-Barré. Usually it's in adults, but we're talking about it. Some children can get it. And basically it means that from your feet, all of a sudden the nerves don't work good. And then you start stumbling, falling, and then it moves up and you might become incontinent or constipated. And then it goes up to your phrenic nerve, another nerve, and says, okay, stop working. Well, now you can't breathe. So what is our main goal for Guillain-Barré is to watch your respirations, watch your oxygen saturations, making sure that they are breathing, because that's exactly what happens. They end up on a ventilator. And it's how much time? 3 weeks, 4 weeks. They're all different, but around a month, you're going to see that. How do you treat it? Number one treatment is IVIG. It's the immunoglobulins, IV immunoglobulins. So again, these children they won't breathe, but remember, they are awake, alert, and oriented. So they know what's going on around them. They're ventilated. We're going to give the IVIG, and then we're going to be monitoring their lungs and their vitals, etc. Now, I've put here all your Kahoots that you'll see. The dosage calc, I've given you many different things about it. If you need any help with that, you just let me know. Does anybody need anything?
No, thank you, Professor.
No, thank you so much.
You are very welcome. If you need something, let me know. Just holler. That doesn't mean that I'm not your professor. I am here to help you too.